Shilpa, we can start.
Yeah, just 1 second, sir. Sir, we can start.
Shilpa, please go ahead.
Sure, sir. Good morning, everybody. So I'd like to first thank Dr. Srinivas sir and Dr. Gansham sir for giving me this opportunity to speak on this platform today. So the topic for today's discussion is approach to tropical infections in ICU. We'd be doing this discussion in two parts. So in today's session, we'd be going through a brief introduction to tropical infections, common syndromic presentations, approach to tropical infections. We'll also be covering dengue and scrub typhus. The rest of the three infections we'll be covering in the next session. So tropical infections are the infectious diseases that occur more commonly in the tropical and subtropical areas. And these are less prevalent in the temperate areas because of the cold season, which checks the growth of the insect population. So the tropics are the regions that lie on either side of the equator between the Tropic of Cancer and Tropic of Capricorn. So it includes parts of Central and South America, Africa, India, and Australia. The various factors which favor the presence of infectious diseases in the tropics, like the environmental factors, changing rainfall patterns and increased temperatures that have led to the increased vector distributions. Also, air pollution because of the increased CO2 emissions leading to decreased air quality, the diverse flora and fauna. Social factors like poverty, overcrowding, undernutrition, limited access to healthcare, and biological factors have all led to the increased growth of the pathogens, vectors, and the hosts. So these infections are caused by bacteria, viruses, and parasites and transmitted by insects which act as vector. So most of these tropical infections have overlapping clinical presentations. So the specific cues to their diagnosis only develop over the course of illness. Therefore, for the ease of the diagnosis, these infections are divided into syndromes. So, for example, fever with rash, fever with thrombocytopenia, fever with ARDS, or fever with jaundice, fever with encephalopathy, or fever with multi-organ dysfunction. So, amongst the list of these various infections, we would be talking in detail about dengue, leptospirosis, malaria, scrub typhus, and melioidosis. So about 20% of all the ICU admissions, according to a data published from Asia, South America, and Africa, are accounted to tropical infections alone. So we need to understand how to approach these infections when they present to the ICU. So the step one would be an initial assessment that would begin with the assessment of airway breathing and circulation, along with fluid resuscitation. So we need to also closely monitor while resuscitation to prevent any kind of volume overload and pulmonary edema. And during resuscitation, we send basic investigations like CBC, CRP, RFT, LFT, blood and urine cultures. And further on, we send investigations according to the presenting syndrome. For example, patients presenting with fever with rash, we need to suspect dengue, meningococcal infections, rickettsial infections, and chikungunya. So we send those respective serologies. Patients presenting as fever with ARDS, we need to rule out scrub, leptospirosis, malaria, or H1N1. So we send the respective serology. Similarly, with fever with MODS or with encephalopathy. Patients presenting with encephalopathy, we also have to do a CT scan to rule out tubercular and pyogenic meningitis. Step 2 would be to take a focused history. We need to look at the pattern of fever, alternate day fever as seen with Vivax or falciparum malaria, or if it's a biphasic saddleback fever as seen with dengue. Other associated symptoms like weight loss, diarrhea, abdominal pain, and other constitutional symptoms. Any travel history to the endemic locations, animal exposure that can increase their risk to tick-borne infections, immunization history, and occupational exposure, wherein there could be chances of increased exposure to contaminated water. So So the third step would be to perform a focused physical examination. That would be a general examination to rule out anemia, lymphadenopathy, jaundice, and edema. And in the systemic examination, we need to look for particular features that can be pointers to our diagnosis. Like in the cardiovascular system, a relative bradycardia is a feature of typhus fever or typhoid fever. Levels of consciousness and seizures. Seizures particularly point towards cerebral malaria. Also features of meningitis. In the abdomen, we need to look for hepatomegaly that can suggest underlying malaria, leptospirosis, or a viral hepatitis. Splenomegaly can point towards malaria, typhus, or typhoid fever. In the skin, we need to look for the presence of rashes and also the presence of an eschar. Eschar is very classically seen in scrub typhus. So the step 4 would be to continue with the general supportive care and specific organ support when needed. And finally, we have to start with empiric-based antibiotics. This would be based on the presentation. So ceftriaxone and doxycycline are the empiric antibiotics for typhoid and scrub typhus and leptospirosis once we rule out malaria. So now this is a chart which shows the treatment that we need to offer based on the syndrome with which the patient presents. I will be talking more in detail about each of these in the subsequent slides as we discuss the particular diseases. This is the algorithm, which is an algorithm of the approach to tropical infections. This was proposed by the ISCCM as part of their management guidelines. So the first step would be to assess airway breathing circulation and look for red flags features like the SIRS features. If they are present, we need to find the focus of infection. Most commonly, we need to rule out pneumonia, pyelonephritis, biliary sepsis, cellulitis, etc. And once we find a focus, we need to send appropriate cultures and start empiric treatment. If there is no focus identified, then we have to look at the clinical syndrome with which the patient presents. And based on the syndrome, as I discussed, we need to send the appropriate investigations. Certain investigations that need to be performed in all patients, like the CBC, platelet, electrolyte, CRP, LFT, creatinine, these are sent. And rapid diagnostic tests, which are performed at admission, like the malaria card test, dengue card test, typhoid dot, and also H1N1 PCR. Now, if these rapid diagnostic tests suggest of a malaria, then we need to start with artesunate, 2.5 milligrams per kg at admission, then at 12 hours and 24 hours, and then once daily. If it suggests a dengue, we need to start with the supportive care and with the isotonic fluids. And if it suggests a typhoid, we go ahead and start ceftriaxone, 100 milligrams per kg per day. And in case if the RDTs do not suggest any of the three infections, then we need to continue with the empirical treatment consisting of ceftriaxone and azithromycin, and then do further workup, send the serology for scrub typhus, leptospirosis, and also do other investigations like USG abdomen and bone marrow examination. So now coming to dengue. So dengue is a very rapidly emerging mosquito-borne viral disease, which is endemic in many continents. The agent is dengue virus, which is categorized under the genus Flavivirus. So there are 4 different serotypes: dengue virus 1, 2, 3, and 4. All of these provide cross protection for a few months after the infection by any one of them, and they confer lifelong immunity to that particular serotype which causes the infection. Vector, the dengue virus is transmitted from the infected persons by the bite of the female Aedes aegypti mosquito. Certain host factors like travel to dengue endemic areas and presence of any secondary dengue infections could be a risk for development of severe form of illness. Even passively acquired antibodies like in infants could be a risk factor for the development of severe illnesses. So, pathophysiology of dengue, it all starts with the mosquito bite that leads to the inoculation of the virus, causing viremia. Now, this viremia causes a direct cellular injury and also an indirect injury. So, direct cellular injury to the endothelial cells and the platelets, causing macrophage activation. That will ultimately lead to severe dengue, which presents as shock, massive bleeding, or with multi-organ failure. Indirect injury is by the production of antibodies, which leads to what is called as antibody dependent enhancement. So basically, the antibodies which are produced could be either neutralizing or non-neutralizing. So the non-neutralizing antibodies which are produced, they combine with the virus. They do not kill the virus. They form a complex which gets engulfed into the host cells, like the dendritic cells. And within these cells, these viruses now tend to multiply at a high rate, and that produces a very high titers of the virus. So, which ultimately causes complement activation and immune deposition. This phenomenon is what is known as antibody dependent enhancement. So, this entire process now leads to vasculopathy, coagulopathy, and organopathy that again causes severe dengue. Indirect injury is also by T cell activation and finally leading to cytokine storm, which again follows the same path. Thrombocytopenia that we see commonly in dengue fever, there are various mechanisms that are postulated for the same, but the most important ones are bone marrow hypocellularity and the destruction of platelets that happen in the liver and spleen, the peripheral sequestration. These happen to be the major mechanisms. Other mechanisms like production of IgM type of antiplatelet antibodies or the dengue virus specific antibodies could be a cause. And it can also be a part of presentation with the DIC as the presenting symptoms picture. There is no rule for prophylactic platelet transfusion. Platelets less than 50,000 uh, with any overt, clinically overt bleeding warrants transfusion, or if it is less than 10,000 and if there are any therapeutic or diagnostic procedures planned, then we can think of transfusion. So now the clinical case definition. The dengue fever includes any acute febrile illness lasting for 2 to 7 days duration with two or more of the following manifestations, that is headache, retroorbital pain, rashes, myalgia. These are the constitutional symptoms and along with the presence of thrombocytopenia or one or more warning signs and symptoms. So probable dengue would be a case that is compatible with this clinical description of dengue fever or with the presence of non-ELISA based NS1 antigen or IgM positivity. A confirmed dengue fever is a case that is compatible with the clinical description of dengue fever, along with one of the following, like isolation of the dengue virus from the plasma, serum, or leukocytes, or demonstration of the IgM antibody titer by ELISA, or demonstration of the dengue virus antigen in serum sample by the NS1 ELISA. IgG seroconversion in paired sera after 2 weeks of a fourfold increase in the IgG titer, or detection of the viral nucleic acid by the PCR technique. Dengue hemorrhagic fever is a case that is compatible with the clinical criteria of dengue fever, plus there has to be presence of hemorrhagic tendencies as evidenced by a positive tourniquet test or presence of petechiae, ecchymosis, purpura, or mucosal bleeding and gastrointestinal bleeds or bleeding from the injection sites. One or more of these, along with the presence of thrombocytopenia, any counts less than 1 lakh, and with the evidence of plasma leakage because of the increased vascular permeability, that is usually manifested as a rise in the hematocrit for the age by more than 20% or a drop in the hematocrit by more than 20% following volume replacement, which is compared to the baseline, and or demonstration of any signs of plasma leakage such as pleural effusion or ascites as we see on the ultrasound, or the presence of hypoproteinemia. So these are the signs which suggest of the underlying plasma leakage. So all these criteria needs to be fulfilled to categorize a case as dengue hemorrhagic fever. Dengue shock syndrome, all of the above has to be present with the evidence of circulatory failure that is manifested as a rapid and weak pulse, narrow pulse pressure, hypertension, cold and clammy skin. So basically, they present with features of shock. In such patients, evidence of plasma leakage, as we mentioned earlier, that needs to be present for the diagnosis of DSS. So the clinical classification of a dengue case, they patients usually are symptomatic or asymptomatic. So the symptomatic ones are categorized into three groups. Dengue with warning signs, the group A, that is further subdivided into A1 and A2 based on the presence of risk factors. So the patients under A1 usually have a normal platelet count with no complications and they only present with fever. A2 are the group that have added comorbidities or other risk factors. This group of patients can be managed at home or in the OPD. Group B are the group which present as dengue with warning signs and with comorbidities. So again subdivided to B1 and B2. B1 are the patients presenting with warning signs and symptoms like abdominal pain, bleeding, lethargy, any syncope, clinical evidence of fluid accumulation as we discussed, and also increased hematocrit. B1 is those presenting with one or more of these warning signs, along with the presence of comorbidities or high risk features like diabetes, hypertension, old age, immunocompromised patients, or patients on steroids. So, these are the patients who have a very high risk of developing a uh, 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 moderate kind of an infection. So, the group B is moderate dengue. These patients usually require close monitoring and they require hospitalization. Severe dengue are the group C patients. So they usually have presentation as a shock, which is categorized as C1, or with bleeding tendencies, or with one or more organ involvement. These patients definitely require a tertiary level management, most often requiring the ICU. So there are three different clinical phases of dengue. The febrile phase is characterized by high-grade fever more than 38.5 degrees Celsius, and the pattern of the fever is biphasic. Lasts for about 2 to 7 days and associated with headache, vomiting, myalgia, arthralgia, and rash. So this rash is characteristically maculopapular or rubelliform rash, which appears after the third and the fourth day of fever, and it occurs over the face, neck, and chest. Bleeding manifestations, mostly mucosal and skin bleeds, can be seen, but depends on the severity with which the patient presents. On physical examination, during this phase, patients can have facial puffiness, conjunctival congestion, pharyngeal erythema, or they can present with lymphadenopathy and hepatomegaly. Presence of petechiae and bruising, particularly from the venipuncture sites because of the thrombocytopenia that occurs, can be seen in this phase. So therefore, it is essential to also perform a tourniquet test. So the critical phase is observed in patients who have a history of previous dengue infections. That is a secondary infection. So these patients, along with those who have comorbidities or any active co-infections, are the ones who go into this critical phase. Now, this phase begins after the third and the fourth day of fever and lasts for about 24 to 48 hours. It is characterized by vasculopathy and coagulopathy, as we discussed. So these lead to bleeding tendencies and ultimately causing shock. Also, there is significant amounts of plasma leakage causing excessive hemoconcentration, all further leading to shock and organ dysfunction. So the shock that we see can be either decompensated or compensated shock. Decompensated shock is usually presented with one or more signs of organ dysfunction, such as change in the mental status, oliguria, and also with features of profound shock like feeble pulses, variable pulse pressures, acidosis, etc. So the third phase is the recovery phase. Around 20% of these patients that present in the critical phase can progress to the recovery phase, and majority of the patients from the febrile phase who do not go on to the critical phase can actually pass to the recovery phase, wherein signs and symptoms tend to improve. So this phase occurs after the critical phase and lasts for about 2 to 3 days. All the extracellular fluid loss that happened because of the capillary leakage now tends to return back to the system, and symptoms and the signs that we observed tend to improve. Now, in this phase, patients can develop a convalescent rash, which is characterized by erythematous pruritic eruptions. And we should be careful while fluid replacement, as it needs to be optimized because they tend to develop pulmonary edema as a result of fluid excess. Now, coming to the lab diagnosis, ELISA-based NS1 antigen detection test is most commonly done to diagnose the acute infections. NS1 antigen is one of the first antigens to become positive. So, this test has a high specificity and sensitivity. So, it can be used for making a diagnosis of acute infections, and also it can be used for differentiating other viruses belonging other flaviviruses. So because of the specificity of this assay. Demonstration of IgM antibodies by the ELISA technique, the MAC ELISA technique, can also be used. That is, between day 5 and day 60, these antibodies are detectable only by day 5 of the illness. In areas where dengue is not endemic, it can be used for clinical surveillance as well. Commercially available rapid diagnostic tests that can detect IgM, IgG antibodies or the NS1 antigens can be also used, which give results within 15 to 25 minutes. But then the sensitivity and specificity of these tests are quite variable. RT-PCR can be performed on the serum or the whole blood samples. These are also a preferred method for demonstration of the virus, but needs to be done within 7 days of symptom onset. Isolation of dengue virus is a very cumbersome technique. It takes about 7 to 10 days, and it is not useful for clinical purposes. Now, coming to the management of patients who present as a moderate disease with warning signs. So they usually present with SBP more than 90, but with signs of reduced perfusion and with a hematocrit rise of more than 20% from the baseline. So these patients need to be taken to the ICU, and crystalloids have to be started at 7 to 10 ml per kg per hour for 1 hour. And then we look for signs of improvement. We look at the BP, pulse pressure, hematocrit, urine output, and the capillary refill time. If there is any improvement in one or more of these, we can then start to de-escalate the fluids. We can gradually make it 5 to 7 ml per kg per hour for 1 to 2 hours, and then 3 to 5 ml per kg per hour for the next 2 to 4 hours, and then down to 2 to 3 ml per kg per hour over the next 2 to 4 hours. So we gradually decrease the infusion, and as improvement would be noted, we can stop the fluids at 24 to 48 hours. In case if there is no improvement seen at the first step here, then we need to look at the hematocrit. So if the hematocrit is more than 45%, which means there is a persistent capillary leakage and these patients require further fluids, we can now we can make the infusion to 10 ml per kg for the next 1 hour, and then further look for signs of improvement, and we can decide to de-escalate to 7 to 10 ml per kg for the next 1 to 2 hours based on the improvement. In case of the hematocrit here remains less than 45%, we need to suspect any severe overt bleeding. So we need to check the hemoglobin and prepare for blood transfusion. So patients who remain to have refractory hypotension, we need to consider inotropes at this point, and also we have to manage them as severe dengue with the decompensated shock. So how do we manage the severe dengue patients with a compensated shock? That is, these patients present with pulse pressures more than 20 mmHg and SBP remains more than 90, and hematocrit more than 20% rise from the baseline is noted. So in these patients, we have to again start fluids at 10 to 20 ml per kg for 1 hour. And then we have to look for signs of improvement. If they are present, then we start to de-escalate in the similar fashion. And if improvement is noted further, then we can stop the fluids at 24 to 48 hours. When no improvement, then again we'll have to look at the hematocrit. If it is remaining more than 45%, we have to give a second bolus, 10 to 20 ml per kg over the next 1 hour, and then look for signs of improvement, and then we can decide on de-escalation. If the hematocrit remains below 45%, again, we have to suspect any overt bleeding. We have to look at the hemoglobin and plan for transfusion. So the algorithm remains similar, like in case if the patients have refractory hypotension, we have to manage them as decompensated shock. So dengue with the decompensated shock, that is their SBP now remains less than 90. We have to start fluids. We have to give a rapid bolus, that is 10 to 20 ml per kg over 15 to 30 minutes, and then look for signs of improvement. If there is any improvement in one or more of these parameters, we can decide to de-escalate in a similar fashion, 5 to 7 ml per kg for 1 to 2 hours, and 3 to 5 for the next 2 to 4 hours, and then 2 to 3 ml per kg for the rest 2 to 4 hours. And as the improvement is noted, we can stop the fluids at 24 and 48 hours. So the algorithm remains similar. If the improvement is not seen, we will look at the hematocrit, and if it remains more than 45, we need to again suspect that these patients require further fluids. So now we give a second bolus, so 10 to 20 ml per kg over 15 to 30 minutes. And if the hematocrit does not improve, we can give a third bolus as well. And based on the improvement, we can reduce the IV crystalloids to 10 ml per kg for the next 1 to 2 hours. So at this point, if the patient remains refractory and we have also considered inotropes, we need to now rule out other causes like underlying cardiogenic septic shock and other metabolic causes like persistent acidosis, or if there is any hidden hemorrhage, we need to look at these and treat accordingly. So for the next 24 hours, if needed, patients can be given additional boluses. They can decide the speed and the volume of the bolus based on the response. So now coming to scrub typhus. So scrub typhus is a disease which is caused by an obligate intracellular gram-negative bacterium called the Orientia Satsugamushi, belonging to the Rickettsia family. So this is an acute infectious disease of variable severity. We see variable severity, and it is transmitted to the humans by the arthropod vector. It can be seen in all age groups, including children. This disease is prevalent largely in the southeastern and eastern parts of Asia. So India, Pakistan, Indonesia, Myanmar, Nepal, Thailand, and other islands are the ones which are commonly endemic to these diseases. And transmission of scrub typhus occurs throughout the year in these tropical areas. It can be seasonal in the temperate areas. So mortality ranges from 1 to 50%. Now, this depends upon the strain of the disease causing bacteria, the immunity of the host, and also it depends on whether proper antibiotic treatment was instituted. So the agent, as we know, is the Orientia Setsugamushi, which is a small pleomorphic obligate intracellular bacterium. And the host are usually the small mammals such as rodents. Humans are accidental hosts in this. And vectors are the arthropods, that is the trombiculoid mites, which belong to the trombiculoid family. Uh, Mostly the larval stages or the chiggers of this mite are the predominant vectors. So large number of these bacteria are present within the salivary glands of the larva, and that is injected into the host when they feed on them. So the rodents, which are the hosts and also the vector mites, they do not succumb to the disease. So they act as reservoir, and the infection kind of perpetuates between the two. So this has a very high mortality and morbidity. The MODS, which is reported, is approximately 35 to 40% in these patients, and around 18 to 30% of these patients require ventilator support. The average incubation period is around 10 to 12 days, and onset of this disease is characterized by the presence of fever, headache, cough, myalgia, and gastrointestinal symptoms. Patient present with pyrexia of unknown origin. And at the end of the first week, there appears the maculopapular rash, which then spreads from the trunk to the limb. In the second week, the systemic symptoms can start. So presence of an eschar is what is pathognomic for this disease. So this is seen at the site of the chigger bite, which is usually found in the groin, axilla, genitalia, neck, sometimes even behind the ear. So it is seen in almost 7 to 80% of these patients. The eschar is basically characteristically seen as a black necrotic center with an erythematous border around it. Complications that can be seen, such as myocarditis, meningoencephalitis, acute renal failure, pneumonia, GI bleed, can occur. ARDS is also quite common. There are certain markers which can predict the development of ARDS, like the presence of a high WBC count, low hematocrit, or a high bilirubin levels. And also, if there has been any delay with the initiation of antibiotics, such patients are prone to have ARDS. Other markers of complications, like the age, that is, any age more than 60, WBC counts more than 10,000, or serum albumin less than 3 grams per deciliter. And also, patients who present without an eschar, these could be markers of potential complications. For diagnosis, serology remains the mainstay of diagnosis. Antibodies, the IgM antibodies appear at the end of the first week, and IgG appears at the end of the second week. So, ELISA for IgM is the most reliable test. It has a good sensitivity and specificity. But the gold standard remains the IFA, indirect immunofluorescence antibody. This test can confirm infection even before seroconversion happens, but they are expensive. And other tests like immunochromatographic rapid diagnostic test can be done. RT-PCR is again another cost-effective alternative to IFA, and this test can also be done on the eschar samples that we can use. Wheel Felix used to be done, but now it is obsolete. So, on the lab investigation, certain characteristic findings like leukocytosis, thrombocytopenia, and transaminitis. With transaminitis, it's seen in almost 75 to 80% of the patients. And patients who develop AKI in severe cases can have creatinine elevation. So, USG at this point can can show hepatosplenomegaly, and chest X-ray can reveal pleural effusion. Coming to the treatment, so tetracycline and chloramphenicol remain the mainstay of treatment, and azithromycin is an alternative, safe alternative in pregnant patients. So the recommended treatment regimen is doxycycline, 2.2 milligrams per kg per dose, BD per oral or IV, and a maximum of 200 milligrams per day for 7 to 15 days, and tetracycline, 25 to 50 milligrams per kg per day, divided every 6 hourly per oral, maximum of 2 grams per day per oral for 7 to 15 days. Alternate regimen includes chloramphenicol, 50 to 100 milligrams per kg per day, divided every 6 hourly, IV, maximum 3 grams per over 24 hours, or 500 milligrams QID orally for 7 to 15 days. Now, supportive treatment includes the institution of NIV or ventilation with lung protective strategy for patients who go into ARDS, and blood and blood products need to be given when the patients present with DIC, and also IV fluids and vasopressors when shock sets in. Thank you. We'll be covering the rest of the infections in the next session.
Thank you, Shilpa. I think it was a very crisp and exhaustive review of the two diseases which we see quite often in this part of the country with a lot of morbidity and mortality. There are a lot of myths and a lot of personal beliefs in treating dengue, especially. But I think what you have enumerated should clarify most of the issues. One of the interesting things about dengue is that the response of platelets when the patient has thrombocytopenia, if you have actually a drop in platelets and a bleeding patient, the solution apparently is not to give platelets to the patient, but try to improve the ADAM-TS level by giving FFPs and cryosupernatant. And this is something which CMC Vellore has studied so well, and one of our own DNB students, Dinesh, also demonstrated the same thing. Scrub typhus. This year, we haven't seen much of scrub typhus here, but last year and the year before, we have seen a lot of patients with scrub typhus with multi-organ failure, predominantly presenting with hepatic dysfunction, acute kidney injury, and at least I can recollect 3 or 4 patients who had encephalitis as a result of blood typhus. So it's not an innocuous disease and it's not an uncommon disease. Ghanshyam, you want to add something?
Nothing much, Yash.
Okay, so I think we'll summarize the whole thing again next week when we look at the other tropical diseases. And those of you who have any queries or comments on or some clarifications on the topic presented today, please do get back to us on the group from where you got the link from, and we will clarify them at the earliest. And please do join us for Journal Club later this month and subscribe to the X YouTube channel. Thank you very much. Have a good day. Bye bye.
Thank you, sir.